BlockHeads. I just wanted to keep this conversation going, and it's something that is I'll let you guys give me feedback while we're going. Let me just share my screen. Hold on one second. Share. Okay. Okay. So what I don't want to do today is talk about complications. And I say that with lightly because you guys, everybody in this room probably knows all the major complications of it. I just want to talk about cases that we've had and something that is popping up in the literature. And I'd love to have a discussion about it as a group. So let me start. Everybody can see my slide deck? Yes?
You're good to go.
Yeah, good. Sorry, I couldn't hear anybody. I'm not looking at the screen. So obviously you guys saw this. This is our paper that looked at complication rates. We had one complication. It was literally one patient that was kind of a questionable last event. And this is the case. It was a max dose ropey for Erector Spinae Plane block. Patient got tachycardic hypertensive. The reason I know this is I got a phone call while I was home from my chair and one of my residents, one of my faculty saying, you know, what the fuck to do. Sorry, it's being audioed. And so I was like, you should push intralipid. Just because I don't want to find out the hard way. So we know this from, I'm not telling you guys know this better than anybody else. Reasonable thing to do. The line of when to push it is really difficult. So I'm going to step back. In 2022, I think it was 2022, Dan, you remember this. We were at Astra, and I went to this talk, and I've been talking about this over and over again. We were in beautiful Hollywood, Florida, and Vincent Chan, he's an anesthesiologist out of somewhere in Canada. Really smart guy. He's an engineer by training. Started this lecture and goes into a room and says, who of you perform Erector Spinae Plane blocks? So I'm going to do the same thing with you guys. And everybody raised their hand. And there was like 4 old dudes in the back who didn't raise their hands. And he's like, anybody think this block is bullshit? And he said it with better verbiage than me. And the 4 dudes raised their hand. They're like, this is a bogus block. And I was like, what? I was like, with Astra? And somebody said this is a bogus block? And I'm like, wait, that doesn't make any sense. I remember I came and told Dan about this. And so what he was saying was that the Erector Spinae Plane block is essentially you're dumping anesthetic in this space and it's spreading, and then you're getting vascular reabsorption, and you're getting a lidocaine block or a ropivacaine block or a bupivacaine block. Joe, you're saying something? Or are you just high? So what are you doing? Oh, he's talking to somebody. And so it was really interesting because I was like, that doesn't make sense. So I came back to my team and talked about this. And they're like, I don't know, Arun, maybe you're just, you go to this conference and you think you're all smart now because you went to an anesthesia conference. But it kind of stuck with me. Do you remember me talking about this, Dan?
Yeah, because it came up a couple of times in other discussions and meetings, and it's like, should we just abandon it or look for those prospective studies that eventually came out?
Yeah. So, right. So this is a piece that was written. I think I can send all the literature on this. And they talk about this, that it's just an intravenous block. And they talk about all planar blocks being just intravenous blocks. Obviously, your chest has higher vasculature and higher absorption rates just because it maintains warmth of your vital organs. So they felt that it was this, they argued this point. And then I don't need to go through methodology. I mean, nothing's perfect, right? We know all those data sets are not perfect. But really talked about the fact that there may not be any utility in this when they compared it in patients. So I thought this was fascinating, and you can read these studies, and what they're saying is that when they looked at pain scores in patients that got intravenous medications versus these blocks, they really didn't do much better, which is interesting. Not 100%, because obviously they're using it for different things. And who in this room has done erector spinae and the patients like the pain got better? I did one yesterday with my intern. We did a serratus, and the patient was like, "This is amazing." So, is this a hematoma block? Right, you're giving lidocaine in the region, plus some vascular absorption, or is it a block? Does it matter? Zach, you don't seem impressed. You're like, who cares?
No, I'm impressed. I never have the balls to do these core blocks, or rarely. So
so let's move on to something that happened. So this is a case we had 5 months ago, 6 months ago, a year ago. I made sure the team wrote it up. I'll tell you the story. So it was a lady that had a sternal fracture and was sitting, waiting, kind of chilling out. Elderly Korean lady. It's a terrible case. The team, I wasn't there, went in and gave, I think, 25 mLs of ropey. And that was her max dose. I think it was 0.5 ropey, which is was a high dose. I can't remember what the number was. I haven't read the case report recently. Patient got the hematoma block, seized, went to full arrest, cardiac compressions, and got, I think, 200, I can't remember the anymore, of intralipid, and came back. I don't know if David's on call because it was David's case, and you might be driving home. We just finished your own club. Do you remember the exact, David? It doesn't really matter, but got full reversed and came back after test compression. Anything I'm missing, David?
No, but I mean, there was a little bit of a miscommunication. Our goal was not to give as much as the big came, but it was 20 mLs, and her max was 25. We intend to give half of that, but miscommunication. Reasons why we should do a block timeout. She got her bolus of intralipid.
Yeah, well, I'll get to it, David. Just it's fine. So, I think what this tells me is, one is absorption rates are very high in the chest, because we've had three now we've had one that needed the heart to be helped with, and the other two just needed reversal. All of them have been in the chest. The other thing is sternal hematoma blocks. Maybe you're just putting an IO in and giving anesthetic in the IO, which it's a good point. One of the editors was making that point, which is a fair point. And then third, I mean, maybe this correlates to what they were saying, when I was in lovely Florida. So I don't know. This is a really interesting phenomenon. So I'm going to tell you what I think is happening, and I'm going to tell you what we did in our hospital, or at least how I teach to my residents, because again, if we have another one of these, it's probably not good. And if this happened maybe at the Brigham or at Denver, it would be, kind of a death for your program. So, I mean, obviously, you guys all have intralipid ready to go. We put this out in ACEP Now right after that, specifically because I think it's good to, we practice how to do crikes. And when this happened to David, it was like, what's a filter? What needle? So we tried to simplify this because we wanted to have it kind of clear to everybody. But I think that what I think in my mind is that when you're doing any thoracic planar block or a hematoma block of the chest, max dose, you divide by 2. Because what you're doing is you're going so low that you're just preventing the process from even, you want to be as low as possible. So again, ultrasound guided regional analgesia than anesthesia. So whatever the block number is, drop it to 1/3 even if you want. 2, obviously they're always on a monitor for 30, 60 minute post block. And 3, I asked them to pause. So I did a serratus yesterday, and my resident would put in 5 cc's, and I would be like, you got to wait now. I'd count to 30 seconds to a minute. He'd put in 5 more. And we gave the 20, because his max dose was like 40 something, over like 4 minutes. And we did it slowly. Again, will this prevent this from happening again? I don't know. But I think the key lesson I've had is that thoracic planar blocks scare the shit out of me. And erector spinae plane blocks, maybe vascular absorption. And I think there's a couple abstracts, which I have not gone back and looked at, in the anesthesia world that have done measurements intravenously post-block and sees these kind of elevations in both anesthetics post planar blocks of the chest. I would love to hear people's thoughts. I don't want to abandon the erector spinae plane block or any thoracic plane block, but I think that if I didn't at least think about this and at least we all talk about it, the last thing I want to hear is Trent calling me up and be like, holy shit, did you hear what happened at my site? So I'd love to hear what other people's thoughts are, if I'm blowing smoke up your butts, or do you think this has some real legs to it?
I think it's good you guys brought it up. I think it's good you got it published. I think it's good to get the conversation started. Can you guys hear me okay?
Yeah.
It's so hard. I mean, I believe everything you're saying is like as a possible thing, as a theoretical thing. I think the physiology makes sense. It's just experience. Everything seems so safe when I do it, right? Like I see so much of it. You're saying that these old school guys are maybe saying, hey, this mechanism is out there. We don't believe in it. It's bullshit. I mean, I had a guy, I was ready to write this up. He was like bilateral bad ribs, like multiple levels. We did bilateral stratus anterior plane, but he had a nasty cardiac contusion and he was getting Brady and we were like resuscitating, but like, they felt it was safe. They felt it was safe for us to do the blocks, and we did do the blocks, and the blocks were safe.
Yeah.
And that's like where I'm thinking, if you have, that kind of patient, if you have vascular absorption, like, and it's going to act systemically at like, I mean, we're talking large volume, right? We did two sides, and we went right up against the max. Maybe we did the max.
So that's the thing, Zan. I think that you won't know until you find out.
Yeah.
Right? That's the problem. And I don't mean that in a bad way. And I'll get to you in a second, Trent. I think that we've done, so many erector spinae plane blocks. We've done so many serratus blocks. And maybe you just need to do a lot of, maybe there's a lot of room in medicine until shit hits a fan, right? And what I don't want is other people to have that same problem. And so I think it just to, at least if I can alert you guys that I'm seeing this, that the next time you do a thoracic plane block, just take your time, maybe go a little lower dose. I'm making these numbers up, right? I'm making the half, I'm pulling that out of my butt, right? Maybe reduce your volume, dilute it, keep on a monitor, just to have that awareness may prevent this from happening at another site. And Trent, you had a question?
Yeah. Hey guys. Sorry, my screen is muted. I'm currently incapacitated from my post-night shift. But I have two thoughts. My first thought is in terms of the anesthetic, in terms of the mechanism. Like, I don't know about you guys, but I definitely haven't been perfect on every single serratus or erector spinae plane block. I've definitely missed the plane, either when I'm working with a resident or when I was first starting out. And if you miss the plane, it doesn't work. Like you don't get good effective analgesia. And when you hit the plane, when you hit the plane, you get good effective analgesia. I guess this is a little bit simplistic, but I'm not sure what the mechanism of action is. But like in my experience, when you hit it in the plane, it works, and when you don't, it doesn't work. And for us, like, so partly from that paper, erector spinae plane blocks being so close to the central nervous system, I think that's the one block that we too at Hartford, like, we're exceptionally careful about because of its proximity to the spinal cord. We always do it in conjunction, usually in rib fractures with our trauma service. So these patients are being monitored. I agree with you, Arun, that we should be careful about these blocks. But I think, like, for us here at Hartford, like the thoracic blocks, like we are pretty careful about. I'm gonna keep doing them. Like they effectively provide analgesia for us. Like, I understand there's safety and we have intralet available, but I don't think this is going to stop me because they work.
Yeah, no, I 100% agree with you. I don't want to stop anybody from doing. I did a serratus yesterday. I've done erectors in the last week. I'm not saying to stop it. I'm just saying to be aware that there is some noise coming from a lot of really smart people, that there may be another mechanism, and one being intravascular absorption. So to one thoracic blocks to reduce volumes, maybe, or to just deliver it slowly and be cautious of it. That's all I'm saying. I'm not going to stop doing any of these blocks. I just think it's just out there, and it's a really interesting argument and a conversation. And the reason I want to bring it up at BlockHeads is because this is the group that's going to change the way people practice downstream, right? I mean, the downstream people are just sticking needles in people. We're thinking about this in a cognitive way. So I'm just, that's, I think you're on the right path. I do, and before you go to Bob, I think that when you get into the fascial plane, right, the vasculature runs in that fascial plane with the nerve. So do you have a higher absorption at that point? Is that what's causing the anesthesia? I don't know. And then somebody posted Twitter, they did a right-sided erector spinae and got left-sided rib fracture pain relief. And I was like, that's bizarre. And so that leads me to believe that maybe there's some vascular absorption component that's causing this.
Yeah, or I guess, sorry, I buy the mechanism totally, like that there's something else that might be going on. I just know that like it also involves us getting to the proper plane. Like you can't just randomly deposit anesthetic into the back near the vasculature and it just works. Like, no, there definitely is some skill involved. Yeah, I'm with you with that.
100%. You, Bob?
I'll be the converse. So I'd say that this is David. We definitely have seen interns that have like missed the plane or like not done a great job, and you get pain control. Like we all have anecdotal evidence. So I mean, I do think there's some validity of like questioning this mechanism. And then I mean, in terms of like the thoracic last case, I think that one specifically, I'm going to be very careful with sternal hematoma blocks or any hematoma block. We never had aspiration of blood, but I mean, I think it really is a direct line to the heart, right? It's an IO. There was definitely the dosing we can question already. I would even be cautious with like even having done half of that dose. I think we have to know that is really kind of a, if you're going to do that block, addition to the timeout, to make sure you know exact dose that you're giving is because our IV was not functioning when we actually had this case. So all the things that we kind of wrote up except now, like I think for these higher risk blocks, having an IV in place is also something that you should make sure is like functioning in addition to having them on the monitor and having your kit, your intralipid kit protocol ready.
Bob?
Hey, just some interesting kind of points, I think is, yeah, I mean, one thing that we've been kind of hearing about, and I haven't done a deep dive on literature, but we're kind of talking about how, with these ESP infusion catheters, that they're noticing that with sometimes these like manual push, or like a higher pressure push is showing better results. So I'm kind of curious about how that kind of fits into this slower volume push. And the only thing I kind of worry about too is I just worry about, if we're really kind of doing this slower interval push, that the people that are already on the fence about doing this, that we're just going to see a further dropout of people actually doing the block because they're, they're not going to take the time to do it.
No, I 100% agree with you. And again, I really, the reason we're doing this at BlockHeads rather than doing this at an ACEP talk, right, is because I want the thinkers in the room who are the ones who are really doing this and not just like listening to other people to then dig in the literature, and we can all have this conversation. I think this is why I like BlockHeads, because it's the idea is to make it a place where all of us talk. So I don't know the answer. I don't want to go out and tell everybody don't do blocks, right? I don't want to tell them not to do erector spinae blocks. I just, for our internal department, because of that event, we're just much more cautious because, chest compressions and bringing someone back from dead is not fun for hospitals. So I think it's just a worry for us, but at least it's just, I just wanted to bring it out there. Is it, I don't know, is it?
And I do think there's a significant difference between the two cases, at least.
Yeah, 100%. One was just tachycardic.
At least the erector spinae case and the hematoma block. They were like, I think there's definitely different, much higher risk profile with the sternal hematoma block versus like the ESP. And what I've learned myself too is like you don't really have to push the dose on your anesthetic. Like I don't know, like you always thought more is better, but like really like you could do this with 0.2% ropivacaine and really get volumes that you need to get that fascial plane spread and still get good analgesia. We've done it ourselves anecdotally, right? Like I don't think you need to push the limit on this. And there is good data, what Arun was referencing, and people that get just single catheter blocks for sternotomies, ESPs, that were having higher plasma levels than what they expected, like for being toxic levels. Again, what theoretically would be toxic when you get these blocks, when you do the dosing that's appropriate, weight-based dosing. So we already know that this exists, at least in the surgical data. So why push the limits, right? So I think the number of where we reduce it to is probably something we can discuss, but I think that the need to go up to that high level is really not there.
And I think it just keeps on going back to our concept of ultrasound guided regional analgesia, not anesthesia. Really thinking of it multimodal. And so keeping these numbers. I mean, I can also give you 10 of dilaudid to reduce the pain, but I'm going to get some hypotension and apnea. Is it Munaza? You had a question?
Yeah, my question was, do you think that it's the volume that's causing this more, or is it the concentration? Like, do you think it's like the unzipping of planes that's causing more intravascular absorption versus it's the dose of the anesthetic?
Again, I'm going to tell you, I may not know the answer to this, but I'm guessing that it's the concentration, and the delivery rate is just the delta. I think it's the delta of the absorption level. That's my guess. So I think David's point's well taken, right? To use a lower dose, use a lower number, and do it slowly, right? That's where we've come to, just to be safe, because I always think that whenever you externally generalize it, right, I'm going to have a physician do it and they're going to do it poorly. If I have him or her just have a little bit of a check, they may prevent this from happening.
Thank you.
Does that answer your question?
Yeah, thank you.
Evan? I remember Evan. Did anybody else have any other questions? I wanted to keep this short and tight. And again, I think Dan sent out the articles because I probably sent it to him before.
I mean,
but I think
just to play devil's advocate, Arun, I mean, then why not quarter it? You know what I mean? Like at that point, it's so arbitrary.
I'm making this up.
Yeah. And then to David's point, like, and your point, after kind of hearing these stories, it has given me a lot of reticence. Just for everyone out there, me and Munaza are PEM, and I think beyond like a program getting shut down, I might get fired if I ever like arrested. No, because they're gonna say like you're one of 5 people in the country who have ever done this. So I took it seriously before, and now like almost to the point where I'm like quite reticent to.
Yeah, but you could do it. You could do a 5 cc block, Zach, and probably get away with it. You can probably do really low dose and get something going. So I think Bob's point is correct. Like, I don't want to tell people not to do this. I just want them to understand that extremity blocks rarely cause last, and all the data really supports the fact that extremity blocks, and it's because I think it's the absorption rate. I don't think any of us are getting in the artery or the vein. So, and I know David, we have that video where the needle, we can see the needle, so it's not in an artery or vein. And then the one Erector Spinae that wasn't in the registry that my resident called me for was not in the vein either. So I think you just have to be just a little careful.
And I mean, I think like we do hematoma blocks on people, right? Like hematoma blocks should have like, it's the same concept of just thinking of the rapid vascular absorption. And I think even myself, I've noticed a lot of my serratuses have transitioned sometimes to like going on the rib, and we're close to those fractures. So I think especially those like serratuses that you're doing close, like you're for all intents and purposes doing an ultrasound guided hematoma block. I'm having a lot more pause now with this. Like, just think about that almost as the same dosing things that you would think about doing a hematoma block in like for a distal radius, right? So just, you're not gonna want that rapid absorption. Assume that because there's a broken bone right there and you're doing an ultrasound guided hematoma serratus, like over where the fracture is, those are probably the ones that are higher risk. But we're not putting a moratorium on hematoma blocks either, right, Zach? So I think like you probably do those sometimes in kids, maybe too, maybe, I'm not sure at what age. So I don't want to say that you can't ever do that. I think just be really cognizant of the volume, and we can dilute anesthetic down to a safe concentration, I think.
I think that's sorry, I jumped on a little late, but I think just to echo some of those comments, I think this is the biggest one to just have caution with, in terms of, especially for training people, especially that people that aren't maybe doing as many blocks, mainly because I think the fascial planes can be hard to get into. And so people kind of equate
maybe a poor performance of the block to volume, even though it may be more technique related. So then they start going maybe more to like an MTP block, and have already increased their concentration on top of that. And that's where I've seen problems. The only issue that we've ever had with last has been with an Erector Spinae that basically was a MTP at too high of a concentration. So I think that's just something to really kind of make people aware of, is just to be more cautious with these blocks. Not that you shouldn't do them, but just to have more caution with those.
Yeah, and I think coming from leaders like all of us, it just allows people not to make errors. Like, oh shit, I didn't know. You know, like just with anything in the thoracic plane, just be careful, slow it down, you know, relax a little bit, dilute, like all the basic things that you would just say, right? You don't have to crike everybody with the tough airway. You have to just, you know, check the neck. So anyway, that's it. I hope that was fun. And anything else, Dan?
I don't think so. I think the major thing is just it might be a balance between venous absorption and targeted nerve, interactions. But then the prospective trials should have shown some kind of benefit with targeted erector spinae. So I think we'll see what happens with prospective data as more stuff comes out, but we should definitely keep our ear to the rail on this.
Yeah, I just think that the Erector Spinae is a 2018 block. I think it came out 2018, maybe a little earlier. So a lot of the stuff, I think what the more you dig into this stuff is the clinical equipoise is still there. There's a lot of like, we don't know. There's a lot of we don't know in this stuff. And it's interesting because everybody's just like, oh, that's what I do. It works every time. And you're like, well, okay. So I think the more that we kind of just check ourselves, I think the better we do. I'm not saying.
Arun, real quick, if people are doing these erector spinae blocks in the future, do you want us to just like, after the block takes effects, just kind of like push on their other side and see if like, is there something like more subjective we can start doing to try and get like, you know what, I did this and every time I do it, both sides are numb and it doesn't matter.
I mean, we published case reports of like erector spinae like reduced pancreatitis. I mean, we were the first ones to do that stupid thing, but like, I mean, I don't know, right? Is it just an intravenous block that we're giving, or does it really innervate? Like, does it really get into the fibers that innervate the pancreas and the somatic level, or the not the somatic level, but I can't think right now. But I mean, there's anatomical belief that it works, but does it really happen, or we're just giving an intravenous block? I don't know. It's interesting.
All right. Well, thank you again, everyone. I'll send out the minutes and the summary, and we'll see those in San Diego that we'll see, and we'll see those in Salt Lake City that we'll see. So have a great one, guys.
Thanks.